am Mahenoor Yusuf, and I graduated from Harvard Business School in 2016 with a PLDA. I'm also co-chairing Harvard in Tech Seattle chapter. Harvard in Tech is the official Harvard University-wide alumni group for technology. We hope to further the development of technology through encouraging innovation, providing resources and network, and promoting technological activity throughout the Harvard community. So this webinar is getting recorded and will be shared at the Harvard in Tech Seattle webpage. I'm here with Roger Hackett, my fellow alum, to moderate a panel discussion on telemedicine.
Hello, my name is Roger Hackett, and I'm a Harvard alumni of HES 2018 and founder of Hiner and Robbie LLC, where we publish children's books and smart play systems for bilinguals.
So we are so glad to have the 6 distinguished panelists joining us today. So Professor Myra White is a lecturer at Harvard Medical School in the program in psychiatry and the law, and also teaches evidence-based medicine to residents. She is a graduate of Harvard Law School and has a doctorate in psychology from Harvard, and MS in electrical and computer engineering from Northwestern University, and holds a patent in computer neural networks. Professor White is joining us from Boston.
Hello, everybody. Am I supposed to say anything?
Thank you for joining us, Dr. White. So next, my fellow HBS alum from PLDA, Greg Jarzabek, co-founder, CEO at Trustedoctor, joining us from London, UK. Trustedoctor, a healthcare technology company, simplifies access to specialized healthcare. He is also a finalist at Harvard Business School New Venture Competition 2017.
Hi, everyone. Thank you for having me here. Thanks for Mahenoor.
Thank you. Next, Hassaan Ebrahim, co-founder, CEO at Hikma Health, joining us from Boston. Hikma Health is a nonprofit that builds software for organizations providing healthcare to refugee populations. Recently, they have added COVID-19 screening tool for refugees. The organization received recognition for its early work, winning the Harvard Business School New Venture Competition in 2019, the MIT 100K's Audience Choice Award in 2020, and entry into the Harvard Innovation Labs Venture Program.
Thank you very much. Thank you for inviting us. We're really...
My next panelist is Debbi Gillotti, Chief Operating Officer at nVoq Inc., Board Director at University of Pittsburgh, IT and Business Strategist, joining us from Seattle.
Hello, everybody. Good morning.
Thank you, Debbi. Debbi has received national recognition for her leadership in the technology field, including America's Best Technology Users from Forbes magazine, CIO, and Computer World Top 100 IT Executives, and has been a contributor to Harvard Business Review and other publications. Next, Dr. Michael Hatzakis is owner of HatzakisMD, based at Seattle. Besides diligently caring for patients, Dr. Hatzakis has a strong interest in leveraging data systems to advance our ability to make better, more informed decisions about what it takes to stay healthier and when and how to best apply medical interventions.
Thank you. It's a privilege to be part of this.
And finally, Chad Hiner, registered nurse, VP of Customer Experience at nVoq Inc., joining us from Seattle. Chad spent 15 years working in some of the most challenging clinical environments, including an Army Combat Support Hospital, a bone marrow and stem cell transplant unit, and a trauma surgical intensive care unit. Chad has been involved in a variety of healthcare IT implementations, and he has been engaged in multiple EHR and healthcare IT implementations and witnessed firsthand the burden that has been placed on clinicians. I would like to add that Chad is a COVID-19 survivor, and we are very glad that he overcame COVID-19.
Thank you very much. Pleasure to be here.
So thank you all for joining us. We are so honored to have you all at this discussion. We will be exploring today if telemedicine is the future of healthcare. So what is telemedicine? Telemedicine is not simply technology, but an innovative medical research that will help the medical team to care for patients and their families. It's the practice of caring for patients remotely when the provider and patients are not physically present with each other. So the global telemedicine market size was estimated at $41.4 billion in 2019 and expected to reach $155.1 billion by 2027, expanding at a compound annual growth rate of 15.1% over the forecasted period. Telemedicine solutions hold great opportunity as they help in improving clinical management, reduce variations in diagnosis, and make effective care delivery by enhancing quality and access to healthcare services. Yesterday, it was reported more than 100,000 COVID-19 cases have been reported to the World Health Organization in the last 24 hours, the most in a single day since the outbreak began. The unprecedented outbreak of COVID-19 across the globe has resulted in increased demand for telemedicine solutions. Social distancing and lockdown implementation by several countries as a preventative measure to curb the pandemic. The impact of COVID-19 led us to explore if telemedicine is the future of healthcare. So I will start with Professor White. How can telemedicine help during a pandemic? Can you share strategies to optimize existing telemedicine services and initiatives for better outcome during and after COVID-19?
Well, I think it's quite obvious that getting to see the patient rather than talking to them on the phone makes a huge difference. And I think that's one of the big differences with telemedicine. You can actually see how someone's feeling. You can also be very creative with the pandemic. You can ask them to check their pulse, and you can actually count or come up with some creative way to do that. You can test their breathing by using your audio. The other thing that people tell me, and I think is also extremely useful, is the fact that you can also see the background where they are. You can sort of see their situation. You can also have them like walk across the room. There's many things that you can do using telemedicine. And one interesting fact that I think is really sort of fascinating is that in neuroscience, when you look at neuroscience studies and things like that, they show that we hear with our eyes even more than we do with our ears. And so, but I think that also creates something that you have to think about when you're doing telemedicine, and that is to make sure you have a good connection. And often that's something you as a practitioner can't actually control in many cases. So I think that's one of the really big challenges, is that the patients you're dealing with may have a terrible connection. There may be privacy issues that you can't speak to them confidentially. Say with a pandemic, someone might be afraid they might have COVID-19 and don't want other family members to know, and whether somebody has sufficient privacy in their home. So I think those sorts of things, while it has many, many advantages, the other thing I think is a limitation can be that people often want to join these kind of sessions on their phone. And what I find is that that really is hard to really see what's going on, and they often have bad connections, and they can't push the right buttons and things like this when they're using their phone. So the other important thing is to make sure they have a good connection. And you also need to plan ahead of time when you're using telemedicine, because let's say with COVID-19, somebody you think they need to go and get tested right away or go to the hospital right away, you should have that information available for them and know where their location is before you start, so that you can, because if they're sick, they're not going to really have the wherewithal to find that information themselves. But I think there's many innovative things that you can do with it. You can also post instructions for them to follow, etc. I don't want to use more than my 5 minutes. Do we have a time limit here?
Okay, anyone else would like to add to it?
I maybe a few words. I really agree with Professor Myra White, because it's I think what we encounter, and it's very important, is to check the firewalls in the hospitals. And it's just, I think many stakeholders in this whole telemedicine is trying to make things rather difficult and easier. So I think getting a connection is probably the most important thing right now.
Yeah, and also I was going to say that some things from the legal dimension of this, and that is that practitioners have to be really clear whether they have the license to treat someone, because there's so many state restrictions on whether you can practice across state lines is another issue that has to be considered. And also for doctors, you need to know whether the service you're using is HIPAA compliant. And there's now a lot of services that provide services that are HIPAA compliant. I know that Zoom does, and I probably shouldn't put in a plug for them, but I found it to be a highly reliable system to use. And but there's all sorts of ones that you can explore. The other thing, though, is from a legal perspective, is that the information that you share with someone in terms of on Zoom, you should remember is discoverable. If somebody, and as another thing is, you need to check your insurance to make sure that you have the proper insurance and that your insurance will cover whatever kind of issues that might arise with a patient. And so that's very important. The other thing is that in a court of law, whatever happens and whatever you say on Zoom is probably discoverable. So if someone decides to sue you, you could be legally liable. You can't kind of protect the exchange of information that you have with people. So I would say there's pluses and minuses. It's certainly great for people who can't get to the hospital. I think it's fabulous in a pandemic, because people may be too sick, or they may be older, and in which case you also have the situation of making arrangements for them to get to a hospital or to get to somewhere that they've been tested. So it also expands, I think, your role as a physician. And the other thing I would say is that in this time of high stress, one of the things that my colleagues have been finding is that people are extremely fearful, and they just, in many cases, want someone supportive to talk to them, and they want some kind of human connection and reassurance. And that's something, they may not be sick, but they may not feel that well. And I think that's something that is extremely important, that can be delivered via telemedicine. It's just the insurance that, you're okay, don't panic.
Okay.
Things will work out. So those are the things, my thoughts on things that I can share with you.
Okay.
I do know that, Dr. Hatzakis, I do know that most of the malpractice carriers actually need to be notified if you're going to do initial evaluations via telehealth. Most carriers will automatically cover follow-up and intermittent care, but you have to notify them that you're going to be doing full initial evaluations by telehealth. So you're exactly correct in that you have to specify with your malpractice carrier the kinds of things you'll be doing.
Yeah. Dr. White, there's a question in the chat for you. I can read it, or our host can read it.
Oh, let me look. I put on my glasses.
Yeah.
Oh, someone has asked whether it should be time to make it easier to practice across state lines. I would say this is a huge problem. You know, each state wants to control, you know, the practice within their state. And there is a push to allow people now, you know, and it's being talked about, but still states are right now, I was actually looking this up because some people had said, well, there's been some, you know, movement to allow people to do that more. But it's very challenging because you might speak to someone and not know what state they're in. In other words, there's no way of telling for sure that you know what state they're in. There is a lot of talk about changing the licensing arrangements or making it easier for people to be licensed in multiple states. But right now, it's one of the biggest challenges.
Okay.
If I may add actually to that, I think that yeah, I agree with somebody asking this question, because I think we should be allowed to, and I think OCR, Office for Civil Rights, actually during this pandemic, because we literally moved like 5-10 years forward with the mindset right now, in this unfortunate times. I think it's actually they relaxed different specialists to be able to practice over different states. Of course, not longer looking at the lobbyists, but more like allowing, because a human being is a human being. I think it doesn't differ whether you're in Houston or in California, I think.
Well, the states like to have, you know, all these little regulations.
Yes.
And, no one wants to give up their
Exactly.
Another thing we've seen is that the nurse practitioners in some states were not allowed to operate without the oversight or affiliation with a clinician, and we're seeing those changes as well. For instance, the state of Pennsylvania was half and half, and they've now gone consistently allowing the NPs to operate autonomously, and I think that's going to be very helpful as well for the ongoing supply of primary care support as we get into the next phase of COVID.
Okay. Thank you, Debbi. So we will move on to the next question. And this is for you, Chad. Would you please first share with us your survival story of COVID-19? What is your experience with the existing healthcare system?
Sure, yeah, happy to share that. What's interesting is I did have a telehealth visit with my primary care provider. And, Dr. White, to your point, it was really reassuring to me to have that face-to-face conversation with my PCP, who knew me and could see me. I actually did it via my iPhone on Zoom, and that was a really an interesting time, because I was not feeling well. My temperature was 103, and I really felt like something was going on, but I wasn't sure. And I really, at that time, this was about 30 days ago. It was April 23rd when I had that appointment. I really wasn't sure, although I had a plan, and it was to contact my PCP and follow their direction. I wasn't sure, should I go in? Should I not go in? Should I do a telehealth visit? What's going to come out of that? And it just so happened that my PCP knew that my wife is a nurse here at the local trauma center who has a COVID-19 unit, and said, look, Chad, you should get tested. And didn't balk at it at all, just said, you should go get tested. So I went from being home on a telehealth visit to then having to get in my car and drive to a drive-through testing center. And I had to muster up the energy to do that. And it was difficult. And I didn't want anybody in my family to be in the car with me. And so this was even before they were, telling everybody to wear masks. But what was really nice is my PCP was able to say, Chad, you have a fever. How are you breathing? I had actually a pulse oximetry, little, finger probe. And I was able to say my O2 saturation is 96%. My heart rate is, I was tachycardic. I was like in the low 100s. My blood pressure was normal. I was able to give them my vital signs, really. And with that information, he was able to say, you're stable. You're likely going to be fine. Most people are. So reassuring to me that if I wasn't having any respiratory problems, I didn't have a cough, I didn't have any of those really, symptoms that are emergent, but he still thought I should get tested. And so I did muster up the energy to go get tested. and I self-isolated. And so those instructions were helpful. You need to isolate, you need to be away from your family, you need to be in a room by yourself, and be very cognizant of, if you go to the bathroom and all those sort of things, food you eat, all those sort of things. So we put those protocols in place rapidly in my home, and I have a family with 2 children living at home. So that was itself very challenging. Fortunately for me, I had about 48 hours of having a fever, and I woke up on a Friday morning and I didn't have a fever. And so I gave myself a fair amount of time off of Tylenol to see if I spiked, off of the medication. I didn't. I stayed with the normal temp. My heart rate came back down to normal. My O2 saturation stayed the same. And other than fatigue, I felt back to somewhat normal. I did have a little bit of, I didn't feel as sharp. I didn't have the mental capacity, and so that was the challenging part, the fatigue and just sort of the fog. That lasted about another week. And then after that, now I'm, about 4 weeks post. I did get it tested last week, retested, and my results came back negative. So I had an initial test by PCR, nasopharyngeal swab, which was not pleasant. I'm not going to sugarcoat that. It was not pleasant. But then I waited 14 days and was asymptomatic and got retested, and that test came back negative. So what's interesting about it, and the question that was initially proposed to me was about microfluidics. And I've been doing some research on it, and I've been having some conversations with some folks about it within my network of people. And it would have been amazing. So imagine if a COVID-19 test was available, rapidly at a large scale with a non-invasive home-based test.
Mhm.
And that is possible with microfluidics. So that concept of, being home, having a telehealth visit, and then being shipped or delivered, same day to my home of a little microprocessor that I can put in saliva and plug it into my phone, and it does the testing and gives me a color reading. And my provider can get that information and know instantly whether I'm positive, and also, maybe perhaps the viral load, or then the follow-up antibody testing. And so all of that stuff is possible. There's some examples out there today with some companies, and maybe, Hassaan, you may be familiar with them, with the malaria testing and the sickle cell testing, and the Gazelle malaria test, for example. It's highly accurate. It's low cost, minimal training. It's $1 per test, and it tests people, rapidly. So it's very sensitive, and just the time, cost, training involved is minimal. So just to sort of wrap up the full complex, I survived it. I'm happy. I'm thrilled that I did. Access to my primary care provider was really reassuring to me. I've been able to continue to communicate with him through the personal through the portal, so we can exchange information, and he's sharing information with me. I asked him, I said, well, how do I get cleared from COVID? And there's really not a good answer right now. And so when I have this conversation with my provider, he's learning as well. And the organization, the health system that he belongs with, their leadership, their infectious disease doctors are helping to guide the delivery. But you get information from so many different places. And so what's the truth? I'll tell you what, as a patient, what the truth was? Not what I was reading in the paper or watching on the news. It was what my primary care provider was telling me. I trusted him, and he helped guide me through it. And so for that, thankful.
Hey, Chad.
We're
So you're the
glad.
first COVID-19 survivor I've ever got a chance to speak to. I'm really curious.
Yeah.
Was there anything in the telemedicine side that you were able to share with other COVID survivors? And I wonder what the limitations are in terms of telemedicine and enabling those types of interactions, and whether they might be useful. It seems like if you're under a lot of stress, you might want to talk to other people who are going through the same thing.
Yeah, I guess there are COVID-19 survivor groups. I haven't joined any. I'm in a healthcare community. My wife's a nurse. I'm a nurse. I have friends who are physicians. I get information, and I shared a lot of information. And so I was the first actually for a lot of people. So it's interesting that you say that I'm the first person you talk to who tested positive. Like, it's actually I don't know anybody else who has it.
Okay.
Unfortunately, I can tell you that a nurse that my wife works with on her unit passed away from complications as a result of it. And so you
Sorry to
do
hear
hear about the the rare case, for example, but I don't know a lot of people personally, so I didn't have anybody else I could say, hey, what was it like when you had it? I can tell you I had a really bad headache and a really high fever, and I needed to talk to somebody, and my primary care provider was right there. In terms of how to share that information with other people, I, I think that don't wait. Get on a call with them, let them hear about. It's one thing to say, yeah, I got a fever. Okay, take some Tylenol, stay home, go back to bed. Well, you know what? Had my provider not known me and said, hey, how are you doing? Oh, you're breathing fine. Oh, your O2 saturation's fine. Oh, you have a fever. Okay, well, take some Tylenol and go back to bed. That sort of classic, take some Tylenol and call me in the morning, right? If that would have been the case, I wouldn't have self-isolated. I would have, likely exposed, the virus to other people in my family, maybe even the community. At that point, we weren't wearing masks. I would have felt better maybe on that Friday morning, Saturday morning. Go, oh, I'm good. Gone to Safeway, got my groceries, came home for the week. So that knowledge and that ability to self-isolate and prevent further infection, was key.
Okay, so I think that's a great segue to the next question. Greg, I'm going to ask this question to you, and I also want you to think a little bit about the question I just asked to Chad, and in particular about contact tracing as well. But telemedicine is an expansive term that covers telepathology, teleradiology, teleobstetrics, telepsychiatry, among other things. So I was wondering if you could give us an overview of the current state and future of telemedicine and some of its services and applications that we might see.
Thanks, Roger, for this question, and thanks, Chad, for sharing your story. And I think it's very important to hear that and draw on this, and I will draw on that. But Roger, you said like telemedicine is a complicated word. I think it covers so many different things that it's sort of like internet in 1998. And when I look at the telemedicine, and let me focus on telemonitoring, telemedicine, which is virtual experience with GP or PCP, how we call it in the US, and actually, if it's possible, also to a specialist. I think it's a very fragmented world. So drawing back on Chad's experience, he said as a patient that he would love to speak to a patient, to speak to a nurse or someone PCP. That's what he did. What he wanted to do next is actually within this digital ecosystem, being able to get this test home so that he doesn't have to travel, so that his journey is not fragmented anymore. And what I think the next step is, which we don't see yet, because telemedicine's been mainly, when people are talking about telemedicine, they're mainly talking about PCP, GP, the first primary doctor. It's kind of easier way to introduce this. But the next step would be, Chad, if you didn't feel well and you have other complexities while going through this, you would like to speak to a respiratory physician who's a specialist, a specialized doctor who actually will guide you further, because the PCP might not be able then to help you. And then if a specialist medicine doctor will have spoken to you virtually and say, you know what, I think it's getting worse, we should send you an ambulance to get you to the hospital right now. All the journey digital. That's what I would love to see the future of telemedicine. At the moment, it's very much fragmented. You have telemedicine companies, call them some telemedicine, selling a software to a hospital just within the hospital, but it doesn't speak to the different supply chains so that it's integrated. Then you have a lot of applications where you have, which is easier to commercialize. You have application, primary medicine sold to a payer, being an employee benefit, sold to a patient. Hey, we have 15 doctors, GP, PCPs, much more homogeneous in terms of education, because of difficulty of finding what to call this and actually teaching, exactly explaining what the situation is with a kind of down-to-earth conditions. They sell it to payers, but if you speak to other companies like applications, if you find something wrong, you still have to be referred to a hospital. And the referral to the hospital is, again, physical appointment. It's not digital appointment. So I think there's connection between the first care to the secondary care and then hospital. And this how I would see the telemedicine being much more developed in the future. And I think PCP and GPs taken off for quite big time in very different countries. United States, there are many companies in every country has kind of like a GP or PCP digital healthcare solution. Mainly it's regional because you do the prescription so you can deliver the care. And as Professor Myra mentioned, you kind of have to be licensed to do that. But I would say what we do in Trustedoctor, we focus specialized healthcare, we focus on oncology, we focus on respiratory physicians, all the difficult stuff where it's very difficult to connect to the right specialists because they're so subspecialized. And those doctors, unfortunately today, 1% of them may be doing some telemedicine, the rest is actually physical appointments. So I think right now we are in the wave of looping the model. And if PCP can refer digitally to a specialist, that's what I would like to see the telemedicine look in the future.
Hey, Greg, so I wonder if you or maybe also Professor White or Dr. Hatzakis can speak a little bit more to something else about COVID, which is the fact that it is something that is contagious. And so it's not just if Chad gets COVID, that's one thing, but Chad has to self-isolate. So if Chad has children or a spouse or anything else that anyone else that's in, if his grandparents want to visit, they can't see him. So I'm curious as to, do we need to think about medicine more holistically from a family standpoint when something like this when we have an outbreak like COVID-19?
Well, totally. I think it's not just COVID-19. I think if you're going through cancer, it's the same story. Like you have the whole family is impacted. So I think, whether it impacts your emotions or whether it's COVID tells you that you have to stay away. I think when you go through a kind of disease that actually threatens your life, I think that, we should be thinking of medicine for the whole family, because it's not just you being impacted as a patient. It's like all the caretakers which are impacted and your family members. So my answer is yes, definitely.
And you also need to protect the family. Like some of the evidence coming out of UK says that the place where people catch it the most are at home. And that's particularly a pressing problem for people who are poor, because they don't have space to get away from each other. And so in part, like in Massachusetts, it spread most rapidly in the poor areas. There's a poor area outside of Boston where it spread 6 times as fast as in the rest of the state. And I think that also happened in New York, is that one of the reasons it had such a severe case was because, people couldn't get away from each other. So sometimes I think, that they should have something, maybe not like hospitals, but places where family members can go and stay, or the person who's sick can go and stay. And the other thing that they say, the place that actually part of the study that came out said the other place that spreads most rapidly is in public transportation, which poorer people are taking. So, but I think it's something, in some ways I find it ironic that you're quarantined to your home, because your home is probably one of the most confined spaces that you spend your time in. And so that's incredible, challenge for a family as to how you deal with that, unless you have like a 10-bedroom house.
It was, I can tell you from personal experience, it was quite challenging. And, the thought though of not being home and being in a separate facility and people delivering, meals to me, for example, that is really, would have been really difficult. Fortunately, my family, my daughter and my wife were both tested, and they tested negative. So they didn't get it. Thank goodness. But the whole isolation thing is another aspect of it. To your point around that next wave of, okay, the PCP says, yeah, go get tested. You test positive. Now what? And I kind of, I'm not sure why, but I kind of expected a more thorough follow-up. I did get a call the day after my test came back positive from the Department of Health, and it was kind of high-level contact tracing. and she, you know, the person assigned to follow up on the lab, she asked me a few questions, and then asked me who I lived with. So it was just the local people in my house. That's it. That's the only contact tracing, was just locally in my house. So there was no, I mean, I hadn't been a lot of places, back to the grocery store and back. Dropped some meals off to some friends who were in need of them. But other than that, no real contact. And I reached out to those people right off the bat proactively and said, hey, look, I want you to know I tested positive. Be aware of these signs and symptoms. But you know, what it really came down, it's just a personal responsibility I think people have, and they have to make personal decisions and within the boundaries. And I guess I was looking for more direction, and so I could tell my wife and my kids and my friends and my parents and explain to them exactly what I was going through and what I needed to do, and this is the timeline. And that was still being developed. I think it's still being developed. I
Well, I
still
want to
don't
kind
think
of
it's real. Yeah.
So I want to kind of move on to this next question, but I want to carry sort of that last theme into the next question as well. And so, you know, I think one of the things what we talked about is how that it's not just the person who gets COVID-19, but it's everybody in the family who gets impacted by it. And I really think for me with my family, I can imagine. I also spend a lot of time with my sons, you know, doing sports and activity and exercises with them. And if I wasn't there to do that, you know, they had to actually stay inside the whole day. That would be brutal for them. But I want to move this question to Hassaan, because we've had a great conversation a couple weeks ago, or maybe it was last week, with the mayor of Phoenix, and she told us that the Navajo Indian tribe was pretty heavily impacted there in Phoenix by COVID-19 for various reasons. And we've also heard, even here today, that there are certain parts of New York and certain ethnic groups and the elderly who are impacted, but there's also this migrants who are impacted. So we've seen news saying that there's 70.8 million people worldwide who have been forcibly displaced, and you know, healthcare is grossly lacking. Infrastructure is also lacking in those communities, and so I really wanted to have Hassaan speak to a little bit about what he's doing and you know, what kind of innovation in telemedicine across borders can we hope to help stand in the gap of that.
Yeah, Roger, thank you so much for that question. I think, you know, as sort of Professor I was talking about, we think about like high density, low income communities as sort of being the hardest hit by the COVID pandemic. And certainly that is nowhere more true than in refugee camps and in sort of migratory populations, where social distancing is not a luxury that people living in you know, 10 people to a small tent can afford to do. You know, washing hands, hygiene, or basic hygiene infrastructure isn't there. And so as you sort of think about how can technology and innovation play a role in that, I think data and digital technology is sort of more crucial than ever. One thing we've found in general, sort of even before the pandemic, is that organizations providing care in low resource settings, whether that's, you know, a rural clinic here in the United States or in a refugee camp in Lebanon, many of these organizations sort of don't have any technical infrastructure whatsoever, whether for record keeping or even for telemedicine. Actually, interestingly enough, you do hear stories about physicians in refugee camps actually using WhatsApp to communicate with their patients. And so, for example, one of our partners operating on the ground in Lebanon was sort of shut down for a few weeks because of the COVID pandemic, and they were actually using WhatsApp to maintain in constant communication with their patients as much as possible. But ultimately, as sort of the pandemic continues to spread, you know, as you said, there are over 70 million displaced people worldwide. We really sort of have to think about how can data and technology sort of help play a role in providing the immediate care. So the work that we're doing at Hikma is really to think about how can we empower physicians who are on the ground and providing direct care. How can we empower them with the data they need to support their clinical decision making? And I think even more so, to sort of what Chad was referencing, how can we leverage the actual devices that are often in the hands of patients themselves to leverage that data to inform clinical decision making? So, for example, like point of care glucometers, you know, you can find really low cost glucometers, and actually, in many of these camps, you do hear that people, you know, have been donated these devices, and they're collecting a lot of their own internal data, but it's never being shared with with their providers. And so now in the era of COVID, for example, even if just knowing someone's temperature and being able to screen for fever can really help with the triage and sort of know who, if testing ever becomes available in refugee camps, who to prioritize, being able to share that data has never become more important. And so right now our model is sort of, we work directly with clinicians and clinics that are providing the care to empower them to collect data. But I think what the real lesson learned here, which we already, I think for the patient perspective, was already sort of well understood, is how do we directly empower people with their own information to keep track of their own records, whether that's here in the United States or abroad. Like I just moved from California to Boston a few months ago, and all of my medical history is in California, and I don't know how to get it to Boston. I assume I fax it or something like that. But so to think about how do we, in this new era, really push ownership of our medical records to us as individuals, I think is sort of the real lesson here, especially as we think about how to respond to COVID in some of these settings.
Do you have any thoughts about how you share across refugee camps that are in different countries? Once you've learned something that was effective in one place, how can you take advantage of that in other places so you don't have to relearn the same lessons? It seems like we've seen some of that happening in COVID-19, where we're relearning the same lessons over and over and again. And I'd like to open that also up to other people on the panel if they have something to say.
Yeah, just to start here, and then agreed, would love to hear from other folks. I think one issue is really that organizations as a whole sort of have no idea what's happening at a holistic level. Individual physicians might sort of have some individual tracking of what's working, but without accurate data collection and the tools to work in low resource dynamic settings, you're not gonna, an organization isn't really gonna be able to understand, well, what function worked really well, where do we need to better allocate resources, and some of these like global international convening bodies like the WHO, or like Gates Foundation, for example, they really have an eye towards how do we approach these things from the holistic perspective. So I think it really is a matter of enabling data collection and observing the learnings at the local level, but then also working with these international convening bodies to share that information and really take earlier intervention or whatever actions could be done to prevent the spread or to make some change.
And maybe if I can add is, I think I fully agree with you, Hassaan. It's very important to share the data, but I think sometimes you cannot share because one application doesn't speak to another application and a third and another application. It's all about the standardization of how you share it. And it's been a long talk about from 2014 actually on FHIR standards. So it's kind of like people design, say, okay, well, let's call disease a disease, not the disease and condition. Let's map it. So if you push to me, we know that disease means condition. And it's actually, I think really is going to take off very soon, because for health, unfortunately, healthcare is so fragmented and so difficult because there are so many stakeholders. Everybody has power: payer, pharma, insurance, and everybody just protecting their own grounds. But and not everybody wants to share the data. That's another thing. But actually, what's happening is we have this new FHIR standard from 2014, and lobbyists such as Amazon, Google, iPhone, Apple, they're actually totally lobbying for everybody producing the same data in the standard. So we kind of like a pre-Netflix story where people were sending like Love Film in UK that Amazon bought, is like before sending a CD, which people still send CD to a patient, and doctors give CDs, and then what do you do with this? You can actually put it on your mobile or phone or computer. But we are literally like, I think we're 2 steps away from Netflix being virtual, such as data being virtual, and it flies between different centers. That would be awesome. And I think that's the future.
I also had a question about how fearful people are in these areas. I know in Boston, in this area that was poor area that was really hard hit, there were a lot of immigrants, and they were very, very fearful, because they're afraid they were going to, if they had a job, they were going to lose it, or they're afraid that their immigration status would be discovered. And so it seems hard to collect data or even know, because people are fearful of the medical establishment, of the legal establishment, and how you overcome that. So I wondered if you have any solution to that.
Yeah, that's a really, really great question. And I think in this population as well, if you're thinking about a refugee who's, doesn't have documentation and is in an incredibly vulnerable state, patient privacy and trust is incredibly important. I think one thing that we do to try to overcome that is just by internally really rigorously holding ourselves to high standards of privacy and security, you know, really trying to build trust directly with the clinics and NGOs that we serve. I think that the doctor-patient relationship is such a special one that I think people really do feel trusting towards, you know, medical professionals who are providing care. I think we've heard stories sort of, you know, the physicians in these communities being the one sort of trusted member, you know, sort of the wise person that they go to, not only for medical issues, but guidance on where do I go for legal resources and things like that. So, you know, I think we really try to lean into that trusting relationship. But ultimately, you know, data collection needs to be, if anything is ever done with any of this data, it needs to be done with the informed consent of a patient. And that also then triggers the issue for us of how do you genuinely achieve informed consent, especially with a population that has a million other priorities before thinking about what it means to sort of give access to data. So it's a really important question, one that I think we can only sort of begin to uncover as, you know, as we really get to understand and know these populations a little bit more.
I think it comes to develop.
Oh, go ahead.
Oh, sorry. I think it comes to culture, and I really agree with the point you guys made earlier about this being a very colloquial world where Epic has its domain, hospitals have their domains, and there isn't a national sense of data sharing. I'm the sort of the chief architect of a national data repository for low back pain and stroke, and we actually, technically speaking, it's not a hard thing to do. From a technology perspective, we actually draw data from 6 different EHRs. Despite there being some non-uniformity of data standards, we're able to extract data from multiple different EHRs. I don't think it's a technology problem, it's a mindset problem. We have thousands of patients now being extracted from 7 different EMRs and being filtered into a national repository. And I think the technology part is, to be honest, is the easy part. The hard part is the political walls around organizations and strategic positioning. You know, this system wants to be the leader, this EHR wants to be the leader. And I think, you know, if we had that mindset several years ago, then we could have employed a COVID national data collection effort somewhat automatically just by sitting on top of a framework that's already built. So for example, we have a national data repository that's collecting data on X condition. We have this emergency. All we need to do is now retool that and pipe that data into that same repository, and really within several months we could have national data on trends and patterns of COVID transmission, who's doing well, who's not doing well, compare the best practices of people who are doing really well against people who aren't doing well, and create a dissemination protocol if we had that national approach. And I think that's a mindset issue really, and it's public health over business.
Excellent. So this beyond border discussion really helped us to identify 2 key areas, right? Legal piece of it, that we need to have a standardized beyond border legal, standardizing the legal piece, and also the technical piece. We need to figure out that how can we have, again, beyond border standardized applications available for all. So it's a good segue to move on to our next question. It's for you, Debbi. In telemedicine, prominent industry participants include Teladoc, Doctor on Demand, IBM, Intel corporations, and many more, right? Vendors are investing in research and development to generate technologically advanced systems in order to gain a competitive advantage over other suppliers and provide economic benefits to the industry. So the market is expected to become highly competitive as many startups are seeking opportunities in the sector. So from a physician and patient's perspective for effectiveness of telemedicine, what are the key technology requirements? What are the technological gaps we still need to overcome in telemedicine?
Thank you for the question. And just to clarify, I am not a practicing clinician and I am an IT person. So I'm going to talk about it from the IT perspective, and forgive me if I misspeak in any way. So I would say this, my company and Chad's company, nVoq, we are a speech-to-text provider for healthcare, and we've been in the healthcare domain since 2011. We were first in the cloud, and we've learned a lot of things over the last decade. And one of the things we've learned is the adoption curve. And I think that that's a really important thing to keep in mind here as we've talked about the use of technology in telemedicine. We are currently in discussions with a number of telemedicine suppliers, software suppliers, about incorporating voice into their product. And part of the thing that's interesting for us to see the evolution of this is when we started in 2011, there was a lot of pushback about using speech with an EHR. People were afraid of all the things you can imagine and privacy and whatnot. Then you had the plethora of consumer apps like Siri that got people very comfortable using speech, and then everybody wanted speech in their EHR. It's a commodity now. So you look at telemedicine, and many of the telemedicine providers are then wrestling with what's the best way to capture the experience, the interaction of the experience, and we're getting asked to take our product to the next level in supporting those types of applications. So I say this, is that with that you have the homogeneous environment that exists in medical offices. We learned this when we started implementing speech. And if you've implemented speech recognition with one orthopedic surgeon, you've implemented it with one orthopedic surgeon, because everybody wants to do it a little bit differently. And how do you address that challenge when many of these people are working at home? We saw this when many of our home care hospice clinicians were forced to adjust to working at home and doing telemedicine, and they're using Macs and they're using this old version of whatever, and the parent organizations don't have the setup IT and tech support wise to deal with this. So it's like, vendor, help out, please. We actually got asked by one of our large home care customers, could you take over frontline support for the doctors, because we don't have enough people to handle it right now with COVID. And we were happy to do that. So the point being that adoption for the providers is not always as easy as one would think. And you can get caught up in the feature function comparison between all these leading vendors. At the end of the day, how seamlessly does it fit into their workflow with what they're doing already with the EHR? And my prediction is the players like Epic and Cerner that are already there are going to have the lion's share of this, either acquiring or building whatever it is they don't have to accompany their current EHRs, because it's just easier. It fits into the workflow they already have. It fits into the pharma pieces. You hear stories about labs and why small labs are not getting business because everybody's got their lab portal baked into Epic or Cerner. Same deal here, I think. So on the implementation side with patients, I think we covered a lot of it already. I mean, there's devices. How facile is the technology adoption at home? This will get easier as people like me age into, decades where we're hopefully still able to remember how to push the buttons. But, I think that the provider side is the piece that people tend to take for granted. And this isn't a diss on anybody's capabilities, but it's just there's so much fragmentation out there. Back to another point that's been made. How do you standardize this from a workflow perspective? So those are my thoughts.
Thank you, Debbi. Dr. Hatzakis, if you could add to it, the clinical aspect.
Yeah, thank you. Yeah, thank you. I think, as a practicing physician for a couple of decades and also as a technology person, this COVID crisis has really provided a huge opportunity that we have to make sure that we capitalize on, because for decades, we've been trying to sell telehealth as a technology solution, but we haven't had the opportunity to really sell the value add. And I think we have to be careful to really analyze and prove the value add that's occurring right now today, because otherwise it just becomes a nice new technology that doesn't necessarily have a great ROI. I did a big study with the VHA for people with MS, a decade and a half ago, looking at people who are disabled. And it turns out that, giving people the ability to have access to early health care prevents disease, prevents complications, where we couldn't do before. So I think it's really important that we very carefully look at, not just this is a nice thing to do, but we have to say, what cost is it going to save? What lives is it going to save? And really document those now and say, hey, there's people who are disabled who aren't going to the doctor because they can't get there. Our studies show that half the people that we surveyed had some sort of a physical disability, impairing their ability to seek access to care. So this can't be a technology solution in search of a holy grail. We have to look at the clinical solution and really create that use case analysis so that when this COVID goes away, we can still make the case to payers that we need to keep it going and not have it disappear once the emergency lifts.
And if I can add, I fully agree. And I think that, and I truly believe that's happened actually, because you mentioned, Professor Hatzakis, that it's about ROI, and it's not only ROI of a clinician, or it's not ROI about doctor or hospital. It has to be ROI across stakeholders. because if one doesn't adopt, the other will just fall apart, and it's like there will be a green light and then just stop. But looking what's happened now, and actually it's good to look at across like top-down approach, saying, so clinicians, the workflow, right? Clinicians want to save time. There is a great workflow if they do it virtually. Patients, of course, we know the benefits, employee benefits, everybody wants quick access to care. So patients were always rooting for telemedicine. So the doctor kind of figure out right now, finally, that virtual medicine is not, it's the same safety kind of, you don't have to, all those layers trying to say, okay, it actually works. So we have clinicians on the road, actually on our side. And then pharma. So pharma clinical trials they just bottomed, right? Like any clinical trials, CROs, clinical trials not happening because nobody can go to the clinical to onboard the patient, etc. So virtual clinical trials are getting off again. So you see then, so the pharma see the ROI. Okay, so maybe in this way we just introduce virtual clinical trials. The doctor sees the benefit, the patient sees the benefit. Finally, I think we kind of moved the mindset 5 years forward, and it actually, hopefully, it will happen.
I think you have to take into consideration you've got another player here.
Which one?
The hospitals.
Well,
the hospitals have a huge infrastructure that costs them a lot of money to run. And if people aren't coming to the hospital, then you've got that problem. You've also got the fact that we don't have, in the United States, there's not nationalized medicine. So you've got, all these different rules and practices in different places. So I know like in Canada, you can go to the doctor and then you can get your lab results are emailed to you, and you often get them before the doctor does. And yet here in the United States, who knows, you may have to call 20 times to get your results.
You can actually flip that on its side, actually, because you're right. I mean, health stores are very expensive, but if you can bill the same amount for a visit, now you've cut your marginal overhead. Because
exactly.
Let's say 30% of your visits are now virtual, the hospitals can consolidate and actually increase their throughput and volume with the same fixed cost overhead. Now you got more revenue per fixed cost overhead, so it's a win for organizations.
Yeah, but they still have these huge buildings, and
yeah, so
they have to just take down and those built-in expenses and all that incredibly expensive equipment that they've purchased. That a person has to appear to get their X-ray.
But on the other hand, so it's a real estate business to some extent, actually. Depends different countries, but
they can house the poor now.
But depends where you plug it in, because if you plug it in at the same time, just following the thought of Professor Hatzakis, is that if you do it virtually, you don't have to locally go to the hospital. Your geographic zone that you can refer yourself to, hopefully over state, is much bigger, international patients, etc. And you finally can actually recruit them for treatment. So there's constant. I think there's cons and pros, but it's like in every time there is more probably cons and pros, but it depends how much the pros weigh, and if they weigh more than the cons, you go for it. And I think that's the mind we have.
And believe it or not, Amazon here shared some space with a hospital for a while. So I think there are possible uses for the actual real estate.
Well, I mean, I think the rural market should be the real market. Because that's where hospitals are disappearing, or immigrant, camps and so on, places like that, where refugees are. They should look at that as a market.
Yeah, well,
it seems like we need to move to the next question.
Yes,
Mahenoor.
yes, we are. So this should be the last question, and for you, Greg, how do smart devices like Apple Watch and iPhone help shape the data and treatment that we use with telemedicine?
Well, I think we partially answered that, but I think it's great. At some point you think they're monopolists what they do, but actually they want to smartly make people centralize the data and create those standards. And I think thanks to them, they can move the lobbyists, and that's what we see. So the Google, Amazon, they want the standardization of data, and that would help us definitely, as Hassaan mentioned, everybody else on the call. And in terms of treatment, I think it's not thanks to iPhone. I think it has to happen thanks to the minds of Debbi or Hassaan that figure out those applications that speak across the holistic telemedicine or healthcare provision, rather than just fragmentation. Because if we don't connect those dots, it's very important that we have to have a virtual way of delivery of healthcare, the same way we do physically. And only when we get that and people are accustomed to do that, I think it will fully get rooted in.
Okay, thank you. We are actually out of time, right? We still have a lot of questions from our audience. Unfortunately, we are not able to address them due to the time limitation. However, later we will upload the recorded webinar resources info and answer to some selected questions at the Harvard in Tech Seattle website. On behalf of the Harvard in Tech Seattle, Roger and I thank you for your time today. Our panelists, Greg, Professor White, Hassaan, Debbi, Chad, and Dr. Hatzakis. Your perceptive insights have helped our audience. Thank you. To the participants, thank you for joining us today. It is remarkable how significantly all of our lives have changed over the past months. We hope you and your loved ones are staying safe and healthy during COVID-19. We are grateful for the connections and strength of the Harvard alumni community. Thanks to your generosity and support. Hope this video will bring in some thought-provoking discussion. If you're interested in learning more, please join us at LinkedIn Harvard in Tech Seattle. Thank you everyone for joining.
Thank you for having us.
Thank you very much.
Thank you very
Thank you.
much.
Be safe.
Great discussion.
Yeah. And
Bye.
thank you everybody for your great comments. I learned a lot.
Thank you, Dr. White.